And moving on from acute diagnosis, we move on to a follow-up of these patients. And essentially, we have Dr. Sudha today talking to us on the cardiovascular follow-up and the role of stress test in patients with Kawasaki disease. This is one of the most important areas, especially in patients who had acute KD, and how do we follow them? Over to you, Mrs. Sudha.
Mr. Chairman, and ladies and gentlemen, I greatly appreciate the opportunity to speak at this session. The first talk is CTA. Long-term assessment for each coronary region, Japan JCS is shown. Maximum intensity projection MIP and multiplanar reconstruction MPR is a useful method. This patient is a four-year-old girl. MIP and MPR are shown. The diameter of coronary artery can be measured CTA. In the left is coronary angiogram and right is CTA imaging. We compared the diameters in CTA with those in CAGs. There was a significant correlations. Thrombus is detectable in CTA imaging. This patient had occlusion of RCA. Coronary wall thickening is also detectable. Appearance of localized stenosis without calcification is detectable. Clinical course of a 9-year-old boy with IVIG resistance is shown. He had thrombus. He had thrombus in the RCA. In this patient, CTA and MRA are shown. Thrombus in aneurysm detected, but the diameter of aneurysm decreased. Segmental stenosis was detected. In the LCA, aneurysm regressed. Sorry. CTA imaging after 1 year was shown. Cellular change coronary aneurysm are shown in this slide.
The maximum diameter of coronary annulus at 2 months is 5.1 millimeter. In year, it is 3.7 millimeter. At 3 years and 10 years after KD, they are 3.3 millimeter and 3.7 millimeter respectively. In the same patient, CRCT imaging are shown. Annulus was regressed. In a 7-year-old boy, CRCAG are shown. In the same patient, CRCAG of RCA are shown. At 7 years old, right coronary artery was almost regressed. In the same patient, CT imaging are shown. Small calcification of both arteries are detected. The next talk is myocardial enhancement by CMR. Perfusion defect indicate myocardial ischemia, and delayed enhancement indicate myocardial infarction. Perfusion defect reflects distribution of myocardial blood flow. Perfusion defect in rest and stress is shown. This picture shows late gathering enhancement. Late gathering LGE as shown. This picture also shows LGN. Also, sorry. This picture, stress in rest and stress, perfusion defect. This picture also shows LGE in patient with segmental stenosis. This slide shows perfusion defect and LGE with segmental stenosis. This slide shows perfusion defect and LGE with shown. Occlusions occurred, LGE detected. This slide shows also LGE. In this patient, LGE occurred after occlusion of LAD. Subendocardial infarction was detected. This slide shows imaging of CMR and MPI. Subendocardial infarction less than 50% was found in CMR, but perfusion defect was not detected. RI spectrum MPI. The last talk is characteristic of coronary flow velocity reserve and transthoracic Doppler echocardiography in patients with a history of Kawasaki disease. Usually, the coronary flow reserve, it is unknown whether the acute inflammation caused by Kawasaki disease will have an effect on the endothelial function of coronary arteries in the future. The coronary flow velocity reserve, CFR, of the left anterior descending artery can be evaluated by transthoracic Doppler echocardiography non-invasively. Usually, the coronary flow reserve is decreased for an 85% stenosis. The method, the coronary flow velocity reserve of the left anterior descending artery, examined by transthoracic Doppler echocardiography in 189 patients, male 125, female 64, with a history of Kawasaki disease, and 10 volunteer control. From 2005, total cholesterol, high-density lipoprotein cholesterol, low-density lipocholesterol, triglycerides, fasting glucose, and hemoglobin A1C were measured at the same time. The patients were divided into 9 groups based on the LAD. Coronary artery lesion was diagnosed with selective coronary angiogram or CT angiogram that had been performed close to the time of CFR examination. Information about the patient in this study was also obtained their record. Measurement. The coronary flow velocity measurements were carried out with Sequoia mainframe with a 7.5 MHz transducer. Hyperemia was induced by infusion of adenosine triphosphate at a rate of 150 microgram per kilogram per minute. The infusion was continued until the maximal increase, about 2 to 5 minutes. During propagation, the electrocardiogram was monitored continuously, and blood pressure was recorded with a digital blood pressure monitor at rest and during hyperemia. CFR was calculated as a ratio of hyperemic to basal mean diastolic flow velocity. This patient, 17-year-old man with an aneurysm of right coronary artery. The coronary flow velocity reserve, CFR, was 2.90%. He had an aneurysm of the right coronary artery by acute Kawasaki disease at the age of 4 years. Rest and hyperemia flow increased. The median age, time of the CFR measurement was 22 years. Based on each coronary artery region, 9 groups divided. Finding in blood sample in the respective group, there were no significant difference in the respective parameter among 10 groups. Measurement in rest and hyperemia were shown. There were no significant difference in respective parameter among 10 groups. This table shows the change of heart rate and blood pressure at rest and during hyperemia in the respective group. CFR was significantly lower, the localized stenosis more than equal to 75%, segmental stenosis and coronary artery grafting group than in the other group. Coronary artery bypass grafting does not improve the native coronary artery stenosis. The CFR after coronary artery bypass grafting may vary in each vessel in each patient with grafting. CFR was preserved in the other group, not only in patients without aneurysm in the acute phase, but also in patients with aneurysms. CFR after CABG group does not improve within normal limit. CFR after coronary artery bypass grafting may vary in each vessel of each patient with grafting, depending on their myocardial involvement. The competition native flow and graft flow after coronary artery bypass grafting is speculated. The competition native coronary artery flow can induce a string sign of the internal thoracic artery graft. Therefore, the measurement of coronary flow velocity is useful to decide for indication of CABG. We think that the cutoff value for the indication of CABG is less than 2.0, which implies significant coronary stenosis. In summary, the endothelial function in the epicoronary artery was preserved in patients with a history of Kawasaki disease and dilated coronary artery lesions. CFR of the LAD was decreased in patients with localized stenosis more than or equal to 75%, segmental stenosis, and postoperative coronary artery bypass grafting. Thank you for your attention.
Is there any difference in the dimensions you measured in the LDA and MCR view? Otherwise, Professor, can you explain the MCR and the LDA you showed in the slide? Professor, you can explain that MDA and the MCR view, that the dimensions she had taken. Is it angiographic view or MRI? The initial slide showed NCR and NBI.
Biparty perfusion imaging. Another is MR based imaging, stress and imaging.
Oh.
That's a, the MR, if you see the images now, madam had showed on nuclear scan, you cannot detect some endocardial. Remember, right? And that's how the beauty of MR. And in fact, given the choice, worldwide, the myocardial perfusion imaging now, the MR is the way forward. The challenge is the availability of the MR scanner. Otherwise, if you see some endocardial functions, some endocardial effects, they cannot detect on myocardial. Hopefully, I have answered your question.
Yeah, same. Any more questions? Otherwise, we conclude. Thank you so much.
For the next session on CT angiography in KD, I would like to call on stage Professor Sujit Singh, Professor and Head Department of Pediatrics, Pediatric Allergy and Immunology Unit PGI, Dr. Tapas Subui, Professor Pediatrics, Sant Niketan Medical College, West Bengal, Dr. Manfoor Singhal, Professor of Radio Diagnosis and Imaging, PGI Chandigarh, Professor Priyankar Pal, Professor and Head Department of Pediatrics, ICH Kolkata.
इसी में डाल दिया ना मैंने। अच्छा उसमें डाल दिया उसको हटा देते हैं ना सब इसी में ही है। सुबह शुरू होगा और फिर राकेश सबसे पहले कौन कर रहा है पर इसमें तो इन्होंने ये बोला हुआ है इसमें आपका दूसरा वो तो मैंने इसमें डाला हुआ है ये वाला ना ये कौन सा है ये हाँ कौन सा है आपने ही भेजा हुआ था और कौन सा ये इसमें हुआ
The next session will be, next speaker is Dr. Rakesh. We need to introduce Dr. Rakesh. Good afternoon. So this change of sequence. Dr. Supil Basu is going to present Mysore CTCA will perform in KD. Dr. Supil, please.
यहाँ से कर दूँ यहाँ पे आगे।
Good afternoon. So, as we have been discussing throughout the sessions that 6 points, na? So, coronary artery abnormalities develops in 15 to 25% of patients with KD, and with treatment it reduces to 5%, and till date 2D echocardiography is the standard of care. But with the emergence of CT angiography, it is a very good mode of imaging modality for delineating coronary artery abnormalities, and its accuracy is comparable to the catheter coronary angiography, which is thought to be the gold standard. So what are the advantages of CTCA? It is non-invasive, can be easily performed during the acute phase once the patient has stabilized, and can be repeated on follow-up. The ability to visualize the coronary arteries and their branches over the entire length with little or no inter-observer variability is a distinct advantage over echocardiography. And also CT angio provides the temporal change of coronary artery lesions, that is resolution, persistence and remodeling, and also accurately delineate the